all of us. So one of the things that falls under health and wellness, and a lot of people don't really talk about, is sexual health. And why? Well, because the more unhealthy you are, the more this becomes a problem, actually. And some people who are very healthy also have problems with their sexual health, both men and women. And I think it's hard for people to talk about it. So I recruited one of the world's experts on sexual health. He's an MD, actually, and this is his specialty. And I thought we'd have a no holds barred conversation with him about sexual health, how he diagnoses, how he treats it. And I think it'll be very useful for people who are maybe too embarrassed to seek out help right now or talk to their primary care physician to get some help with this. It's a lot of information, and so we're going to divide it up into two separate podcasts, one for men and one for women. And I think it's going to be very useful for all of us. So Dr. Joshua Gonzalez is a board-certified urologist who started medical school in Columbia University on the East Coast. He then completed his training at Mount Sinai. So this is when we do our residency training as physicians at Mount Sinai. And then after that, he did additional fellowship training at the Sexual Health Center at UCLA. So he is more than adequately trained, incredibly well trained in this field. And he specializes in the management of male and female sexual dysfunctions, hormone management, and urology. And I think he just joined the podcast. Hi, Dr. Gonzalez. How are you?
I'm good. How are you?
Great. Thanks for joining.
Yeah.
I was just doing your introduction, so it's perfect timing.
Awesome.
So I probably didn't do you justice at all. So I'd love to hear a little bit about your story and how you got into this field. I mean, it's one of those things. I don't think there are many MD specialists in sexual health, are there?
There's not. I mean, sexual medicine is sort of it's not something that we're taught in medical school. It's a field of medicine that brings into the study of sexual health lots of different types of providers. So there's not a lot of urologists, but typically, you see urologists, gynecologists, sex therapists, other kinds of mental health providers that kind of focus on sexual issues. So it's kind of a cool hybrid group of clinicians who have a particular interest in sexual health.
Right, and it's amazing because, like you said, most of the sexual health practitioners I've met have been mostly from the psychology, mental health realm,
Right.
And just to have that unique combination of being a urologist, someone who's actually done surgery and treated people from an anatomical, medical perspective, and bringing that into the evaluation and treatment of these people, I think is very, very useful because, as we both know, sexual health is not just a psychological issue, right?
Right. Yeah. I mean, that's a lot of what I do actually when I initially meet with patients is kind of dispel that myth.
Yeah.
And unfortunately, it's a myth that's propagated, by the medical community a lot of times too, because if you don't have the training to sort of treat these issues or recognize the nuances of these issues, a lot of people, both men and women, aren't believed, and they're just, told that it's all in their head. And so, they may have already felt some of that themselves, and then to hear that from a provider can be pretty detrimental. So a lot of what I do when I first see them is tell them, look, if you actually look at data on sexual dysfunctions, it's overwhelmingly a multifactorial issue. Certainly there's going to be the psychological aspects of it, because if you're sexually dysfunctional, that's a really important part of how we see ourselves, our identities, how we interact with the people that we love and, have relationships with. So of course that's going to create anxieties and there's going to be a psychological component, but, in a majority of cases, there's an underlying physical component as well. And so if you're not addressing that, or at least evaluating that, then you're missing a big part of the picture.
Right. And it's hard to know what actually comes first. Is it the psychological issues and then potentially led to physical issues, or physical issues that started first, that kind of came out of nowhere, and then you have the psychological kind of trauma of that, where you now feel stressed out and anxious about actually being in the bedroom, right? And so
right. Yeah.
it's an important component of it. And I feel it's really great to talk to you because I feel it's almost a necessity for people to be evaluated on the anatomical, physiological standpoint as well, right?
Yeah, I mean, I think it never hurts to evaluate it. And there's been a handful of cases of depending on what particular issue we're talking about that, we go through the physiological workup and everything's fine. Um, but at least even in those cases, I see the value in having these patients see me, because if it in fact is primarily a psychological issue, that's anxiety reducing for patients to go through that process and see, okay, we did these objective measurements. It's not a physical issue. Now I can feel comfortable going to see a sex therapist or going to see a psychologist and working on reducing my anxiety. They feel more confident that this is something that can be tackled,
Right.
because they've gone through that process. So a negative workup, I often tell patients, isn't a bad thing. It's just we're going to go through this process together to rule out any of the possible causes of your problem.
Yeah, yeah. And you're based in Los Angeles, right down the street from us, actually, West Hollywood, which is
Yeah.
fantastic. So, yeah, give me an idea of like the number of people that you see. What percent are men? What percent are women? And kind of the age range of the people that you're seeing as well. Just big picture.
Yeah. I mean, that's why I love what I do, because I never kind of know what kind of patient I'm going to get. The large meta breakdown, I guess, of my practice would probably be about 60% men, 40% women. But the age ranges, I mean, are incredible. So I think, we don't see adolescents generally, but I have a few 18-year-olds in my practice. And then I'm treating a woman who, is primarily seeing me for menopausal management, who's 84.
Mm,
So I see a wide range of ages. And, sex is one of those things that we start very early in our life, and depending on the person, sometimes want to continue, you know, throughout the rest of our life. And, I keep saying sex, but um, a lot of what I do involves hormonal management. And so even removing the sex out of that, there's a lot of hormonal issues that present later in life that I can, be of great help with, just to maintain quality of life, not even referring to sex.
right, right. Well, and it's really interesting to me that you see 40% females and 60% males as well, because I mean, a lot of times when we think of sex issues, we think mainly men and erectile dysfunction, but women also have sexual issues. And I know you've been so gracious to agree to do 2 hours with me, which is fantastic because I think it's just too big of a topic to cover both sexes in one podcast. So we'll do two different ones. And I think we can hit a lot more in depth on each topic or each
Uh,
sex actually. So I really appreciate you doing that. So I want to talk about men in this particular podcast. Is that fine with you?
yeah, that's perfect.
Great. So okay, let's think of your kind of typical male patient. I would assume 40-year-old guy comes in. He's been putting off coming in for a while with erectile dysfunction. Isn't really getting any good advice or feedback from the supplements he's been using and other things he's tried on his own, just from the internet and his research. Where do you start with this kind of a guy? Yeah, first of all, is that like your typical guy? Let's say media,
Um,
middle of the
yeah,
road guy, or
I think, um, from the male side, erectile dysfunction is certainly one of the things that I see the most. Historically, ED has thought to have been mostly a problem of older guys, right? So, like, a lot of times we're trained in, residency, you not even the 40-year-old, you're seeing like the 60-year-old, right? um, and that's the Medicare patient. For whatever reason, and this may be because, of where we're based in LA, where people kind of, I think, put some priority behind being healthy and maintaining healthy and preventing, preventative health. I have a practice that actually skews pretty young. So the 40-year-old is, commonly a patient that I see. I see guys in their 30s. I see guys in their 20s, very often, complaining of erectile dysfunction. And so I guess the first thing that, that I want to impart on the listeners is that if you look at data on men seeking help for erectile dysfunction, on average, most of those men are waiting 5 to 10 years before they
Wow.
seek. And I'm hoping that we'll see a change in that, because patients are certainly being a lot more proactive now with their ability to look, to research providers on their own using the internet. That certainly will hopefully change things in the future. But that's a really long time to have a sexual health problem and not really talk to anybody about it. I think men in general are pretty bad about seeking help for any kind of health issue, and there's a certain pride that goes along with your ability to perform sexually, and so there's shame that kind of creeps into and interferes with people or men wanting to seek help, specifically for sexual health problems. So I think those are the sort of barriers that we're up against. So when a guy does come to see me, that's often, what I ask him is like, how long has this been going on? And it's not usually a matter of like weeks or even months. Sometimes, most of the time, this has been going on for years. So I ask them what kinds of treatments they've tried. A lot of guys, like you said, they'll look up things on the internet. They'll try those pills that you see at
Mega Man 20 or something like that. Like all
right,
these pills.
right, like the rhino pill that they see at the liquor store or like the gas station. They'll order things online, sometimes not even from this country, from other countries.
Right.
They will pop a Viagra that a friend of theirs gave to them. So people kind of experiment many times before they see me. Or some of them have actually talked to their primary care doctor, who is not trained to kind of deal with the nuances of their problem, and often will just say, we'll try this, give them a Viagra or Cialis or whatever. So it's pretty rare that I see patients that haven't tried something. Some of the younger guys have not really experimented, but yeah, that 40-year-old comes in, he's probably tried one of these over-the-counter pills or a Viagra or something, and it doesn't work. And the truth is that that's often what's kind of thrown at patients, because as providers, generally we're not taught about other options or how to appropriately diagnose the problem. So
Right.
that's what I spend a lot of my time doing. On the first visit, we figure out what they've done, any potential comorbidities that they have, to try to get a sense of what the potential factors are that may be causing their erectile dysfunction. And thankfully, it's kind of a finite number of reasons physiologically that men can have erectile dysfunction, and I go over that with them when I first see them, so that they understand how we're going to kind of go through the process of diagnosing what the problem is. So, the first thing I review with them is that you can have a hormonal issue. Testosterone is a really important hormone for maintaining normal erectile function, but there's other hormones that kind of interplay with testosterone that are important to evaluate, and that can positively and negatively affect not just erections but sexual health in general. So we kind of just do a comprehensive hormonal screen when we see them. And I tell them, you're 40 or you're 35 or whatever. Most people wouldn't think that you could have a hormonal problem because of your age, but it's a very easy thing to screen for. And I often, think more liberally in terms of what I think a hormonal problem entails, because as you probably know, if you look at someone's testosterone, the range of normal depends on the lab, but it's pretty wide. I mean, it's, as an example, 300 to 900 or something, right? And if you have a 35-year-old who's having erectile dysfunction and maybe complaining of, decreased sex drive and fatigue, has all of those hypogonadal symptoms, and you check their testosterone and it's 325, somebody who's not, trained to kind of deal with these issues will say, well, you're in the normal range, it's fine. But the truth is that at 35, your testosterone probably should be higher than that, and you have symptoms that we associate with low testosterone. So even in those patients that fall within a normal range, if they're not what I would consider optimal, we'll often still put them on treatment to get them to that optimal range, just so that we can at least cross that out as a potential factor that's playing into their problem. So,
Right.
Yeah.
Well, that's really important because I think, that's a key point, is that a lot of times people will see their primary care doctor. And like you said, we probably get like 1 or 2 days on sexual health, if that, in medical school, right? So a lot of primary care physicians and, people who are not educated in this field as much as you are, they'll look at that lab value and just say it's normal just because it doesn't, put a little red box around it, in the range, and the testosterone level really does differ from person to person, individual to individual. And you're saying you go more based on symptoms rather than what the actual level is. And you're right, it should be a lot more for someone who's in their early 30s or earlier in ages, right?
Yeah. And I think what we do is we have very specific goals. So, again, using that person with the low normal value, there's, data to suggest that guys who have testosterone levels in, at the very least the middle of that range, but often in the upper third of that normal range, that they tend to have better erectile function. Like, there's data supporting that. So that's usually our goal. If they're 325 and we're talking about the 300 to 900 range, I tell them, listen, if we can get you to like 700, 800, that's going to be optimal for your erectile health. And so then we talk about the potential treatments on how we can do that, so that we can at least not worry about the hormones being a factor in their problem. Now, that's just one physiological cause, right? So the other big thing that we evaluate in my office is blood flow. Obviously, the erection is a vascular, the penis is a vascular organ. To get an erection, you have to have quote unquote normal blood flow. And what a lot of guys don't appreciate is that there's the hemodynamics of the erection are really unique. So, often, without getting too, science or medical, often, circulation involves an artery bringing blood to, some end organ or some tissue, dropping off oxygen and immediately circulating out the waste products through the venous system, right? So you get a constant circulation of blood. In the erection, you don't see that. And in fact, if you have that, you can't have a normal erection. So we get blood into the organ through the artery, same way. And then the penis expands and actually collapses or shuts off the venous system. So you don't have blood moving out. And men can have problems, men who have vascular erectile dysfunction can have problems with either of those components. So they can have an arterial insufficiency where they're not delivering blood into the system quickly enough. Or they can have what's called a venous leak, where the inflow isn't a problem. They're actually delivering the blood just fine. But for whatever reason, their tissue doesn't expand uniformly and they're not collapsing and shutting off the venous system. And so they're leaking blood out. And there's, we spend time evaluating that. And we do that using an ultrasound to know more about the hemodynamics of what's going on, because the treatment that I'm going to prescribe them is going to be based on what kind of problem and the severity of that problem. Because I don't want to waste their time. I don't want to throw a pill of Viagra at them if I know it's not going to work. Because my goal is to address the physical issues so that we can reduce any of the anxiety stuff, right? The longer someone remains non-functional or dysfunctional, or tries things that may not be appropriate for them and finds it frustrating, the more you're going to allow that anxiety to kind of continue and propagate the problem. So my goal is to kind of spend a little bit of time understanding what the problem is, physiologically, and then coming up with solutions for those problems so that we can reduce anxiety as quickly as possible.
I love that because rarely have I ever heard of anyone getting a workup for ED and getting an ultrasound actually of their penis. And I mean, it just makes total sense the way you explain it. It is a vascular organ; it needs blood to come in and venous blood to just kind of stay there during the erection phase. So, could you give us an idea of how that ultrasound works? Like, what's the process for a guy who comes to your office? Can he get it done the same day, or is it a long process, or how does it work?
It's not a long process. I mean, the visit ends up being close to an hour. The procedure itself is probably closer to like 10, 15 minutes. Um, we usually will see them as on like an initial consultation and then have them come back for it just as a separate visit, but usually within like a week of their initial consultation. Um, but basically what it involves, and this is the part where patients get a little squeamish, is the thing is we have to study the penis in the erect state, right? So we have to administer a medication that is going to give patients an erection reliably, because if they just came in and we relied on them to get an erection on the spot, no one would be able to do that, because you're in this like clinical situation with these like fluorescent lights, and it's the most unsexy possible. So the way that we do that is we actually administer an injection of a medication. It's an intracavernosal injection. So we actually inject them in their penis, and with this medication that maximally dilates their blood vessels, so that we can get a rush of blood into their penis. Now they still, after they get the injection, we give them some privacy. They have to kind of stimulate to get the medicine working. But that's how we can kind of guarantee that we're going to study their erection in the best possible way, because you want to understand in the best case scenario what their body is capable of doing,
Right.
or not doing, if there is a problem there. So I always try to instill in them that the needle going into the penis sounds horrible, and no one is really excited about it, but I tell them it feels similar to like if I took a thumbtack and just poked you very quickly. I mean, we're using like an insulin syringe. It's very, very small, and most people are actually surprised at how little it does hurt.
Okay.
So I try to sort of like calm their anxiety about that on that initial visit.
Yeah, yeah, doesn't sound like it'd be a ton of fun, but the information you can glean from that, I'm sure, is just a ton of information. And like you said, if you can figure out an anatomical cause, then or a blood flow cause, I mean, that's half the battle, or more than half the battle. So, is that what's the name of that medication, by the way, that you inject?
So it's a compounded medication.
Mhm.
We usually use a compound called Bimix or Trimix. The Bimix is two medicines. They're called phentolamine and papaverin, and then Trimix is the same two with alprostadil.
Got it. And why can't people use this stuff just at home when they need to have an erection? Is this?
Oh, they do. Yeah, yeah. So the benefit of doing the ultrasound with me is that it's both diagnostic and potentially therapeutic, right? So if I'm seeing a guy who's already said, I've tried Viagra, my doctor gave me Cialis, and they don't really work for me, the ultrasound is really, really useful, because number one, it tells me what kind of vascular problem they have. Maybe it's not appropriate for them to be using pills, because based on their ultrasound, they're not going to likely to respond to them. But then we also get to in real time assess their response to the injections, and if they respond really well in the office and they're interested in using these medicines, I can teach them how to self-administer and prescribe them to them so that they can use them at home.
Wow.
And I'm there are some urologists that will prescribe these medications without doing this ultrasound, and there is some danger in that, because if men use intracavernosal injections and they're not appropriate candidates, or no one has assessed what strength of the medicine that they should be using, because there's a bunch of different strengths of this kinds of medicine, and they can actually be at risk for something called priapism, which is where they get an erection that doesn't go away for hours and hours and hours, and then you start to have, a lack of oxygen to that tissue, and you start actually getting, death of that tissue. So it's an emergency actually when that comes up. Um, what we do in my office is take the time to figure out what the appropriate strength and dose of the medicine is for those patients. And then one thing that I do that's sort of unique from most people who are prescribing these medicines is we teach them how to make the antidote. So there is a medication that can reverse the process. So I teach all of my patients how to mix and administer that, and tell them, if you get to 3 hours and your erection hasn't gone away, don't hesitate, just administer the medication. And it's the same process of giving themselves the injection. So that's easy for them to get over. But thankfully, knock on wood, I haven't had patients ending up in the emergency room needing
surgery.
Yeah, irrigation, or drawing out of the blood in their penis, because they're just they have the antidote at home. They can take care of it themselves. So
super smart. I bet most of the people listening to this might not even know that that's an option to have an injectable, because there are a lot of people that Cialis, Viagra just does not work for,
yeah.
and they kind of give up at that point. Like that's the end of the line for them, because they don't know that there are other options that could potentially work. So why does this injection work, or how does it work differently than Cialis or Viagra? Maybe you could talk about how the pills work and how this is different.
Okay. Yeah. So the pills, are absorbed systemically, right? You swallow them, they get metabolized by the liver. The way I kind of describe it to patients is that 100 milligrams that you're taking, right, of the, say, Viagra, you swallow that, part of that gets metabolized by the liver. So it reduces, you're not actually getting 100 milligrams of medication. And then it sort of gets dispersed throughout your body, right? Part of it does work on the penis, but it dilates all your blood vessels, right? It causes vasodilation everywhere. Which is also why people have side effects from Viagra and Cialis. They have, unwanted effects elsewhere in the body because they're being absorbed systemically. So that makes them, even for patients who respond, sometimes unreliable, because they can be affected by what you have in your stomach. Did you just eat a big meal? Have you been drinking? All of these things can affect metabolism, right? So one of the big complaints I get from patients is that the medications, even when they work, can be somewhat unreliable or unpredictable. The injections work differently. So you're injecting them directly into the tissue where you want them to work, right? So the degree of systemic absorption is dramatically less. It essentially just works in the organ that you're injecting. So there's very few side effects from the injection medications other than the minor discomfort of the needle going in there. You can get, some bruising, and if you're not doing the injections properly over the long term, sometimes people will develop scarring. But that's another thing that we go over with patients, is how to appropriately inject the medication. And there's some steps that you can take to minimize those effects. So they don't get the headache, they don't get the muscle aches, they don't get the facial flushing, they don't get the blurry vision or blue vision. That, all of those are side effects that are reported with some of the pills. If once they get used to doing the injection, even the pain, or discomfort that they may have initially experienced with their injections is no longer a factor. So, for the right patient, the injection can work incredibly well, and it's reliable, every time if you're doing the injection properly. So
Nice. And so can you use it like once a week, every other day? How often is there like a limit to how often it can be used?
there isn't like a dose limit. You can't use more than this. I definitely tell patients they shouldn't use it more than once a day. I tell them, ideally I wouldn't want you to use it more than 2 to 3 times per week. Because if you think about that, like over the course of a month, if you're using it 3 times per week, that's like 12 times you're injecting yourself. And depending on what their problem is, another option for them, if they're interested, is we also do penile implant surgery. So
Mhm.
for either guys who have really bad venous leak, who may not respond to injections, um, or for guys who are just really sexually active. I tell them, listen, if you really want to have sex like every day, over the long term, the penile implant might actually be a better solution for you. Number one, you won't have to inject yourself as often, um, and you'll have an even more reliable form of an erection, which through the surgical implant. Um, so there's not like a definitive you can't use it more than this number of times per week, but I just try to assess kind of what their goals are, in terms of what recommendations I make for the injections.
Very nice. So you mentioned implants real quick. I'm really curious because the last time I saw penile implants was, 20 years ago when I was doing surgical residency. I'm sure they've advanced since then.
Yeah.
What is the current state of penile implants, and which is the one that you feel works the best? How does it work?
So there's different types of penile implants. The one that is most commonly uh, the surgery that's most commonly performed is the insertion of what's called an inflatable penile prosthesis, right? So there's two companies that make them. They both work really well. I think it's just kind of a matter of more of surgical training, what you feel more comfortable, which device you feel more comfortable with. And there are certain patients that may be better candidates for one versus the other, but they work very similarly. They're essentially hydraulic systems
Mhm.
that involve three components. There is the cylinders that get hard, that get implanted in the penis. There is a reservoir that holds fluid that is recycled over the course of the lifetime of the device. And then there's a pump that draws the fluid out of the reservoir and into the cylinders. And on that pump, there's a release valve that undoes that process. It draws the fluid out of the cylinders back into the reservoir. So it's a closed system. It sounds really scary, and when I start talking when I start talking about this with patients, they think that there's going to be all of these like robotic parts on their body, that it's going to be visible. And the cool thing about it is that it gets all implanted through one incision, and none of it is visible. So what I tell them is, you could literally walk around naked in a locker room with your device, not activated, sort of in a flaccid state, and no one would be able to tell that you have this device in, unless they sort of reached down into the scrotum where the pump is and they felt it. But you could have someone, close up to you, just looking at your junk basically, and they would never be able to know that you have this device implanted. So I spend a lot of time sort of dispelling their ideas of what this means. And the device that we have in the office for them to see, it looks scary. I mean, it looks like a bionic penis. You know what I mean? Guys are like, oh my god, that looks awful. And a lot of times they're very reluctant to even hear about the penile implant. But the truth is that if you can dispel those misconceptions, and they're the right kind of patient, that would do best with a penile implant, then it's a really great solution. I mean, the satisfaction rate with the penile implant is above 90%, which is kind of remarkable for any kind of prosthetic surgery. Whether you're talking about knee replacement or hip replacement, I mean, that's a very, very high satisfaction rate. So
Absolutely, yeah. So is it like a surgery that you do when you're under anesthesia, and like how big is the incision, and how long does the surgery take to do it? Like what's the recovery like for something like that?
yeah, so it's definitely a major surgery. I mean, so it's you have to do it under general anesthesia, in most cases. It's not like having a huge incision in your belly with like bowel surgery or anything. It's not that major, but it's a major surgery. The incision, it can be done two ways. So the incision can be in the scrotal skin, which I like because once you heal, it sort of blends into the normal sort of folds of the scrotal skin, and you don't really see the incision. You can also do what's called an infrapubic incision, which is just sort of above the base of the penis, kind of on the lowest part of the abdomen. And that eventually kind of gets hidden in, the pubic hair. So you don't even see that, when it's done that way either. Um, and, in terms of how long it takes, it's usually like less than an hour in the operating room. And then the recovery, it kind of depends on the surgeon. Some patients are sent home that day. Other patients will spend one night in the hospital. And then, I tell them, you're going to be bruised and swollen and have some discomfort for the good part of a week. We send them home with pain medication. It's very manageable pain. And it really depends on the patient, as with most things in medicine, like people's pain tolerance can, vary widely, right? So I had one guy who, not, against my approval, got, 3 or 4 days after his surgery, got on a plane for work and like went to Miami and, basically back to his routine a few days after surgery. Um, and I've had other patients who are still reporting discomfort at like 3 weeks, so it really, but I think that's more patient specific. And a lot of those patients I anticipate that with, because they'll tell me beforehand, I have a really low tolerance for pain, so I kind of know that that's coming.
Yeah. Wow. And do people still enjoy sex as much with having an implant in, or even doing the injections? Is it still like an enjoyable experience for them? Does the experience change at all?
To be honest, I think that they have a better experience,
Mhm.
because you have to remember, these guys that are having to use some of these more aggressive measures, right? Like whether you're talking about injections or penile implant, they have a true physiological problem that has probably been present for a long time and made sex very unenjoyable for a very long time. So that's, can be really rewarding for me, is finding a solution for them that makes them functional reliably. And once they start engaging in sex again, after they get over the hump of like, the idea of having to inject themselves, once they see the result and once they start having sex again, sex becomes really, really fun again and
Mm.
very, very enjoyable. And the same is true for the penile implant. The guys that most often get penile implants are the ones with really bad venous leak. And the reason for that is that the pills and the injections work on the arterial system. So they dilate the arteries, right? But we already talked about how sometimes the problem is not the arteries. So some men with, more significant venous leak won't respond even to the injections, and the implant is their best option. Um, so for those guys, it can be incredibly rewarding, because they don't have medical options. They can't try anything, and so they can't have sex. They can't be functional at all, and this allows them that. So many of those men, that's why the satisfaction rate, I think, is so high, is that you're taking someone who's, as non-functional as possible and giving them the ability to perform again.
That's awesome. Yeah, because like you said, I mean, it sounds like there's two major problems anatomically that can happen with the vascular system, either the arterial insufficiency or the venous leak. And if you don't have a treatment for venous leak, the implant is probably going to be your best option. And it's great that you have an option for that, because without that, there would be really no other options, right?
Right. Yeah.
Venous. Is what about the gains wave or the shock wave therapy? Do you do that? And what do you think about that? What is that for?
Well, that's it. So yeah, so that's an interesting area of sexual health that's just sort of like in its infancy, right? So shockwave therapy has been used in Europe for more than a decade, and the data that have come out of Europe are pretty promising. Now, most of those studies didn't distinguish between the type of vascular issue, for instance. They just took men with ED, right, and treated them. So we don't really have a good idea of, from a vascular standpoint, who would benefit the most. And there's clinical trials ongoing in this country looking at the benefits and the potential risks associated with shockwave therapy. We are doing shockwave therapy in my office. I want to be very clear about distinguishing it, because you mentioned GainsWave, which is a proprietary machine that is being sold and marketed to all kinds of physicians. They base a lot of their reported benefits on data from Europe. The problem with that is that their system is not equivalent to the kinds of shockwave therapies that were done in the European trials. The one that we have in our office is a German-based company that has an American arm, and it is equivalent. It is actually a true shockwave energy system. So I wrestled with this for a long time about whether or not I wanted to incorporate this into my practice, because I like to base things, the treatments that I offer patients on, real data. I'm not there to like waste their time. And I felt comfortable after learning more about the machine that we eventually ended up getting that it would offer some benefits. So we've been doing it now for a few months. And I have offered it to patients who are looking for a solution maybe between injections and surgery. But I'm very transparent about it. I tell them, the data are limited on this. The good news is that if you look at all of the data, it's a very safe treatment. So there's basically no adverse effects. And I think it's about proper patient selection in terms of who is likely to respond to it best. But it's a nice thing to be able to offer to patients, because not everyone is ready to just jump into the surgery. It takes people a while to get over their fear, their anxieties, or the issues that they may have with the thought of surgery. And so, yeah, I've had, patients and choose the shockwave option. And to be honest, I mean, this is not the best kind of evidence that we like in medicine. It's, strictly anecdotal, but we haven't really treated anybody who hasn't had some positive response. Now, I try to, before their treatment, sort of manage their expectations, right? Like if you're a guy who is using injections, I'm not going to promise that this shockwave treatment is going to make it so that you don't have to use the injections anymore, right? The goal would be to take someone who maybe is not like responding that well to the injection, say someone with venous leak, and have them start responding better now, so that they don't have to go through the surgery. They can now use the injections. Or if someone is using a really low dose of the injection, and doesn't love it as a strategy, maybe we can get them to start responding more reliably to the oral medications. And that both of those situations are a huge win. But I don't make, I'm not here to sell snake oil, and I'm not here to make false promises. I don't tell them that they're going to have the erections that they had when they were 18 years old again, and all that sort of stuff. So I think when you manage the expectations of patients, and are transparent with them about what they can expect, then I think it is it's a great thing to be able to offer.
Yeah, and for the people who are listening that don't know what shockwave therapy is basically you have a little wand that goes on the penis and that puts some energy-based treatment into the penis that's pretty much painless, right?
Yeah, so the worst I've heard it described in terms of how it feels is sort of like if someone was taking a rubber band and flicking your skin. Mm-hmm. So it's really, very, very little discomfort, if at all. Like I said, that's a worst case scenario. The way the energy works is essentially, you're correct. It's sort of like a probe. It looks actually similar to an ultrasound probe. Mm-hmm. It delivers sound. It's a sound wave delivered in the form with a specific amplitude that makes it a shock wave. Essentially, that energy gets absorbed by whatever tissue you're treating. The cells of the tissue, it causes the cell walls to shear, which then releases growth factors. And those growth factors are thought to, promote new blood flow to the area and recruit stem cells to help regenerate that tissue. So that's important to understand also, because that means that the treatment, that the effects of the treatment are going to occur some time after the treatment, right? So you're not going to get a shockwave treatment in the office and like boom, the next day you're noticeably better, because that regenerative process takes weeks, sometimes months. So I'm in that aspect also realistic with patients and tell them, we're going to probably treat you with 6 treatments. You may see some improvements throughout the course of your treatment, but I don't want you, I'm not going to promise you that. The real effects are seen weeks to months after we complete the series. But many men are reporting improvements throughout their treatment process, which is great. And so we're still, like I said at the beginning of this, we're still in the beginning stages of understanding how to appropriately pick patients for this and who are the best candidates for this. But the good news is that we're not doing harm. No one has had an adverse effect. I mean, not just in my practice, but again, if you look at all the studies, there's really no adverse effects associated with this.
Right.
And we know how it works in other areas, right? Like this shockwave treatment is been used in orthopedics. Like the Lakers and the Clippers have the same machine we do, and LeBron is getting his shoulder treated with the same machine that we're treating your penis with. So it's been used in orthopedics, it's been used in wound healing, and they've shown dramatic changes to like diabetic foot ulcers treated with this machine. It's really, really remarkable. So we know that it has a positive regenerative effect on whatever tissue you're treating.
That's pretty amazing. So that's a whole other kind of mechanism of effect of treatment. So you have your medications that you can inject or take orally that will increase arterial flow. You have, if you have a venous leak, you can potentially use an implant, but this is actually regenerative therapy being applied to the penis, to where, you're using stem cells, growth factors to regenerate tissue in a basically younger, more youthful fashion. Kind of like, what about like, and that goes with the corollary of why not inject PRP or stem cells into the penis? Do you do that as well?
Yeah, we do PRP in the office, and stem cells are a little bit harder to get.
Right.
So we do PRP, which I think you guys use at Next Health. It's a very, it's an office-based procedure. It essentially is a blood draw that you then, have to spin to get the platelet-rich plasma. But yeah, we do that as well, and sometimes we combine it with the shockwave therapy, where for your listeners, the PRP works in a similar way, right? You inject the platelet-rich plasma, which has growth factors, and those growth factors, like we talked about with the shockwave, recruit stem cells and new blood flow to the area and can have the same effect. So yeah, we do PRP in the office also.
Great.
And again, you're correct. It is really nice to be able to offer a regenerative option, because until recently that wasn't possible. It was like you had pills, you had injections, you had surgery, and that was kind of it. And there are a lot of guys that fall in the cracks, that may not respond to the medicines, but they don't want surgery. And this is something that's really, really nice to offer with basically no adverse effects.
Yeah, that's really awesome. So I think we've gone through almost all the treatment options. The only ones that kind of stick out of my head are like the penis pumps. Does anyone still use those, the pumps? And how do those work, and what do they do?
I don't use them a lot. First of all, like, guys hate using them. So yeah, I use them usually in combination. I mean, for specific patients, they can be useful. Say you have a guy who had prostate cancer surgery, right? We know that you get atrophy of the penile tissue because there's a change in, and sometimes a disruption in either the nerve supply to the penis or the blood flow to the penis. So in those patients, as part of what we call penile rehabilitation, vacuum erection devices, which is the medical term for penis pumps, can be useful at preventing atrophy. But I'm usually combining those with some other medical treatment. So I'll put them on a daily PDE5 inhibitor like Cialis, or maybe have them use Viagra concurrently, to try to just maximize their blood flow so that they don't get the atrophy. So vacuum erection devices I use mostly in combination with medical therapies, but in very select patients.
Got it. Great. Okay. Am I missing any other treatment modalities, or is that pretty much the
There
big one?
there are a couple intraurethral treatments. There's one that's been around for decades. It's alprostadil, which is one of the medicines that we talked about in Trimix,
Oh,
in the form of like a little suppository that you put into your urethra. It I don't really prescribe it because most men don't like cringe at the idea of putting something in their urethra. And one of the main complaints is that it can cause burning as it dissolves, which if you're trying to be in a sexual situation, if your penis is on fire, it's not going to make it so easy for you to get an erection. Um, so I rarely prescribe that. One of the compounding pharmacies that I work with makes an intraurethral gel, also made of the components that we talked about in Trimix, that has been a nice option for some of my patients, that they put into they sort of squeeze out of a syringe into their urethra. And it has the same effect as the little suppository we talked about, without the burning sensation, as it gets absorbed. Um,
does that alprostadil, is that increase arterial flow? How is that one working?
yeah, so that's like a very powerful vasodilator. So
Not
it works on the arterial system.
interesting. Wow. I mean, I doubt anyone who's listening to this, or very few people listening to this, unless they're a urologist, really even understand kind
Yeah,
of the breadth of treatment options available. I mean, gives people a lot of hope, right? Because most guys are sitting at home thinking if Cialis doesn't work, nothing's going to work.
right. I mean, this is, one of the things that I do on the first visit I have with a patient is tell them, I say, I promise you, once we go through this process of figuring out why you have your problem, we will get you an erection one way or the other. You just have to be open to my suggestions, because my suggestions are going to be based on the problems that we
Right.
find. And, I tell them that might involve pills, that might involve, injections, that might involve surgery, but I'm going to recommend what is best for you. And if you're willing to go on that journey with me and take my suggestions to heart, you will have an erection. You will be able to have sex again
Right.
in some form, in one form or another.
And do you talk to them also, like a lot of people that are just overall unhealthy, like people who are couch potatoes, super stressed out, or just busy executives that, like you said, your one patient's always on a plane and maybe they have some pre-diabetes, some high blood pressure. Like, what's your conversation to them about their overall health and how that relates to sexual dysfunction?
Yeah, I mean, I think I'm fortunate, and you probably can relate to this also. Again, we live in a part of our country that has puts a lot of priority on health.
Right.
So I do have those conversations with them, but to be honest, a lot of the guys that I see are, they're exercising regularly. They're, doing keto or paleo, or they're doing, they're watching what they eat. But I tell them, what your doctor tells you is good for your overall health is good for your penis, right? So getting regular physical activity, cardiovascular exercise, eating what traditionally we've thought of as heart healthy diet options, getting good sleep. That's really important. Trying to reduce stress. All of those are avenues that you can look into to try to help improve your erectile health. And I use those concurrently, as we go through that process, as we work up their physiological issues. I definitely want them to optimize whatever comorbidities that they have. But I've had conversations with colleagues of mine that work elsewhere in the country. I don't do a ton of penile implants, but I think it's because the patient population that I see aren't necessarily candidates for it. So, I have a colleague who works in Atlanta, and in the South, you've got a larger proportion of patients who have diabetes, who have hypertension, who have obesity issues. And those are going to definitely lead to more severe cases of erectile dysfunction, usually falling into the vascular category, right? So, he's doing 40, 50 implants a year,
Wow.
because he's seeing those patients, right? So he's seeing those patients that aren't going to respond to pills, whereas or injections. Whereas here, a lot of my guys will. If we optimize things for them, they very often will respond to the medical therapies, or even if they are a surgical candidate, they're interested in these sort of regenerative therapies because they're like, well, I want to see if I can become functional again, on my own using this regenerative option.
So that's really interesting. So kind of like the more unhealthy you are, or just globally with issues such as obesity, high blood pressure, diabetes, all these things, or just metabolic syndrome in general, you're going to be less responsive to medical therapies. Is that what you're saying?
Yeah, because we know that those comorbidities increase your risk of having vascular disease, right? So
Yeah.
the penis is the erect penis is an interesting phenomenon in terms of how we understand global cardiovascular disease, right? Because some people in my profession have referred to it as sort of the canary in the coal mine, right?
Mm.
So there's a lot of data that have come out in the last decade or so that have shown that men with undiagnosed cardiovascular disease who present with erectile dysfunction may benefit from having an evaluation, a more formal cardiovascular evaluation, because if you think about it, the blood vessels to your penis, the arteries, are a fraction of the size of even the arteries in your heart, right? So you're more likely to present with erectile dysfunction as your first symptom of cardiovascular disease than you would with chest pain or a heart attack or a stroke, because the size of the vessels that supply those other organs are significantly larger than the ones that go to your penis. So it really doesn't take much in terms of like an atherosclerotic plaque to cause a pretty big disruption of your penile blood flow. And so like I said, there's data supporting formally evaluating those men, especially guys that are younger. Like if you see that 40-year-old and he has no known cardiovascular disease and he's presenting with vasculogenic erectile dysfunction, you may want him to see, if not his primary doctor, maybe a cardiologist to investigate that further and try to optimize his overall cardiovascular health.
Yeah. So it's kind of like an early indicator of heart disease, actually.
Yeah.
So people who are experiencing erectile dysfunction need to at least consider having a more formal cardiac evaluation, is what you're saying. You probably refer them to their doctor to do that, right?
Right. Yeah.
Yeah. So, okay, what an incredible amount of information. I do want to touch a little bit more on some of the psychological aspects around erectile dysfunction and just male sexual issues in general. So, how do you kind of evaluate the psychological aspect of the brain aspect? Are you asking them about things just like about their sexual desire? Say it's not a hormonal issue. Say their testosterone's fine. They're still having sexual desire issues. Maybe they're using porn a lot. I mean, how do these things factor into what you talk about?
So I mean, those I get at those a lot of times just through my initial evaluation with them, right? So I ask questions that can kind of clue you into how much of a psychological component there may or may not be. So, I ask patients, number one, how long has this been going on? Is this lifelong, or has this been, there was a period of normalcy, quote unquote normalcy, and now you're having a problem? Are you waking up with erections or getting them while you're sleeping, right? If are you having problems with your erections when you masturbate, or is it just an issue when you're having sex with partners? All of these things can clue you into potential psychological aspects, because if you have let's say you have a 25-year-old guy seeing you for erectile dysfunction and he's never been able to have quote unquote normal sex, and he reports that he can masturbate fine. Like his erection, it gets hard, stays hard during masturbation. That's not an issue, and he wakes up most mornings with an erection. Then that makes me start thinking. We don't not go through the process. We still do the formal physical evaluation, but that starts to make me think, okay, well, there seems to be some underlying psychological issue also. And so once we go through the physical process, if we've ruled those things out, then I say, we went through this process, everything is negative. This appears to be mostly a psychological, anxiety-driven issue. Here are some people that you can work with on that. And I work very closely with sex therapists and psychologists who kind of focus in this space, because I don't have that training. So I will refer them to specialists to work on that. I try to do that work up front to get an idea of why I think they're having this issue by asking the sort of very specific questions.
Makes total sense. And how does porn factor into the whole equation? I mean, I read a lot about too much porn can definitely affect your ability to have an erection, etc. What are your thoughts around that?
So I would classify myself or describe myself as sort of sex positive. So I don't have a problem with porn use or anything. I think that it can be detrimental if people put more value into their arousal, the arousal that they get through pornography versus interacting with another person. But if you look at the data, I went to a conference recently where they presented sort of the arguments, pros and cons. And if you look at the data, there's actually
And cons of porn? Really? There's a conference about that?
well, it wasn't a porn conference. It was a sexual medicine conference. But someone did give a talk on sort of the myths of pornography in sexual medicine, right? And there is this tendency to think of porn as bad and think that it is mostly detrimental to sexual health. But the data actually don't show that. They're mixed, and there are some studies that actually show very positive effects of pornography use. So what I have found in my practice is that men, it's more about sometimes their masturbatory sort of behaviors, because when you're when you're by yourself and you're primarily relying on porn, the way that we sort of masturbate, the gripping or whatever, the behaviors that people engage in to masturbate sometimes can't be reproduced through partnered sex. Like that same sensation, for instance, if you're gripping really firmly when you're masturbating, you can't always recreate that sensation when you're having sex with a partner. And then it becomes increasingly difficult to sort of trigger that brain response that eventually leads to, ejaculation and orgasm, or your ability to maintain your erection because you're not getting that same level of stimulation. And that's something that I definitely discuss with patients, but again, we'll usually refer them out to a sex therapist, because sex therapists, aren't just talking to them about, their anxiety and potential, things that came up when they were younger that may be affecting their sex. They're actually talking about behaviors. What are you doing when you masturbate? What can we do to change the way that you perceive the sensation and the way that your brain interprets that, so that we can replicate that during partnered sex?
So should people maybe even take like a detox time away from masturbation, or do you think there's just a different technique, or what kind of things do they recommend? That's the issue.
Yeah, I mean, I think it depends on the person. I definitely think, if patients tell me that they're watching hours of porn a day, I encourage them to try to, reduce that. But I don't talk to them because at that point, if they're telling me it seems that it is interfering with like the other aspects of their life and maybe preventing them from engaging with potential sexual partners. But I don't approach it from like a porn is bad, therefore you need to cut down on it, because I don't believe that is the case. But I do think that trying to reframe their relationship to porn is important.
Yeah.
Seeing that to try to teach them how it can be useful and not and used as an adjunct to healthy sexual relationships rather than a substitute for those.
Got it. And what about some of these more like newer therapies that I'm reading about, like peptide therapy to increase sexual desire? Have you heard about those? Are those useful at all?
So there's a medication that was FDA approved earlier. I guess it was in 2019. That is it's called bremelanotide, which is a peptide that affects the brain. It's delivered through the form of an injection, like a pen auto injector. And it was approved for women with a condition called hypoactive sexual desire disorder, which is a fancy way of saying, low libido, low sexual desire, that's not better explained by some other cause. And so that is the only, peptide that I prescribe, because again, I, as much as possible, try to prescribe medications that have, good clinical data supporting their use and are FDA approved. That's not always possible. Like we mentioned, the Trimix, that's not an FDA approved drug. It has to be compounded, and there's certain medications that are not available that we have to have compounded. But in general, if there's an option that is FDA approved and regulated, we use those. So that's the only real peptide that I have experience with.
Do men use that one too, or is it only made for women?
I mean, I prescribe it off label for men. What I tell men is that it can, your brain works the same way as a female brain when it comes to sexual desire and sexual function. There's a that maybe we can talk about in the female podcast that led to this drug and then another drug for the same condition being approved specifically for women. There was a long decade-long fight to get any drug approved for women, and finally these two did. So it's kind of ironic because I have some men who are like, well, what the heck? Like, why is this only FDA approved for women? And what I tell them is, I'm like, listen, you have like 25 to 30 medications that are FDA approved for you to use to improve your sexual function. Women have 3. So, it doesn't mean that we can't use it. It's just that it won't be covered by your insurance. You may have to pay out of pocket for it, but it doesn't mean that it won't work. So I certainly use it off label in my male patients.
Awesome. Very cool. And what about, does psychedelics have any role, or MDMA, in the treatment of sexual disorder? Are you hearing anything about that?
I don't know too much specifically looking at MDMA. I'm trying to think of any studies that I've read about. No, I mean, I can't think of anything off the top of my head. There is a lot, especially with the recent legalization and the growing legalization of like marijuana, there is an interest now in understanding how that can positively or negatively affect sexual function. And anecdotally, like I've seen patients who find that it helps, and other patients who, one of the things I have to tell them to do is to kind of cut back on their marijuana use because it seems to be having a negative effect. And the data kind of are mixed. So we don't
dose dependent, or
we don't even know. I mean, we don't know. The way, unfortunately, it's not federally legal, so you're not going to get large like NIH grants to study this kind of stuff.
right?
So that it makes it problematic to study in a clinical setting. And then the studies that thus far have been done, they're focusing on one formulation, right? Like usually inhaled marijuana, right? They're not looking at, edibles. They're not looking at these, oils or other methods of delivery. They're not usually separating between strains. Like, is it primarily THC that patients are getting? Is it CBD? So there's still a lot to be learned from that aspect. So it's interesting. I mean, it's exciting that there is an interest, because I think for some patients it's been shown to improve their sexual response and their sexual health in general, and other patients it's actually can have the opposite effect.
Yeah, yeah. I mean, it's a whole new wild west out there on CBD and THC,
Yeah.
and it seems like, I mean, there'd be psychological mechanisms of action, and also physiological mechanisms of action. It's
Right.
going to take a lot of research to kind of suss those out and what's what. So great. Is there any other things that you want to talk about as far as a treatment of male sexual dysfunction? Anything else that we didn't touch on?
Um,
Big picture.
I think, yeah. So I think, I mean, we kind of there's other issues that come up. You know, we talked about low libido a little bit. That is, a multifaceted thing as well. A lot of times it's a hormonal issue. It can be a combination of a hormonal issue and sort of like a brain chemistry issue. So sometimes we use medicines that kind of influence neurotransmitters in the brain, um, that can have a positive effect on libido. So that's another big thing I see. And then, without getting too much into it, I will say another big population of men that I see in my practice have pain, and it's unbelievable the ways that pelvic pain specifically can negatively influence sexual function. So that's a whole nother, I mean, literally we could do a whole nother podcast on that. But um, there are guys for various reasons who have chronic pelvic pain that can be, lower abdominal, penile, scrotal, perineal, um, pain that, of course, when you have pain in that area, it's going to have negative consequences on how you're able to have sex. And many patients will actually have an increase in pain with arousal or with ejaculation. So, it sends signals to the brain that this sex thing that you're doing is painful. I don't want to do this anymore. And so sometimes they'll develop, erectile dysfunction related to that. They can't get an erection because their brain just doesn't want to have sex because it's a painful experience. So I see a lot of male chronic pelvic pain, and kind of try to, again, sort of diagnose why they have that issue, help them fix that issue, and then get them functional again.
Wow. And then anatomical issues like Peyronie's disease, and I'm sure that you see some of that stuff too, right?
Yeah, yeah. So Peyronie's disease, for those that don't know, is traditionally been thought of as sort of like a wound healing problem, in the tissue of the penis that then leads to some sort of deformity. So the deformity classically is a bend; it's like a curve, but it can present with penile shortening, or there's like other kinds of deformities where we describe them as like hourglass deformities, but basically a change in the appearance of your erect penis. Um, is definitely something that we see and and treat in the practice. And just because you have a curved penis doesn't mean that you have Peyronie's disease. So we try to evaluate that. Even for guys that I see with ED, I ask them sort of screening questions for Peyronie's disease, like has there been a change in the appearance of your penis recently? Do you have pain with an erection? Because that's another symptom of Peyronie's disease in the acute phase. So I usually ask that when I'm just examining them, to see if, because some guys, are more focused on their erections being good, and they don't even mention that they have this new curve, like that, wasn't
Hmm.
always there. So
Right. Interesting. Wow, what a huge topic. So I think, we covered a lot here, and I know you're just a huge wealth of information. There's so much more we could talk about, but we still have to talk about females. So we're going to do that next week, Dr. Gonzalez, and then we'll just keep having you on. I mean, we could talk about stuff forever, but this was a great intro primer. Where can people find you actually if they need to see you or, have questions?
yeah, so you can, I mean, I have social media presence. So I mean, I'm on Instagram at Joshua Gonzalez, with two Z's, MD. Also on Facebook, Joshua Gonzalez MD, and then on Twitter, at SexMedLA. My practice, as you mentioned, is near West Hollywood. It's on Olympic. Our phone number there is 323-607-2895. Um, You can go to my website. There's a ton of information on my website, other podcasts that I've done, other blogs that I've written on all of these topics, both male and female. And that's just joshuagonzalezmd.com. And I just would encourage any of your listeners, whether they personally have an issue or have a spouse or a partner with these issues, that just get more information. Figure out that there are definitely solutions out there for all of these problems. So if you're not having satisfactory sex and you're having issues with sex, then definitely go to the website and figure out how we can help you. My sort of motto is have better sex, because we should all have the right and privilege to have satisfactory sex, and if you're not having that, then figure out a way that you can.
That's awesome. What a great way to end a podcast. Thank you so much for this. This was fantastic, and I can't wait to talk to you again soon.
Yeah, me too.
All right. You take care, Dr. Gonzalez.
Take care. Bye.